Good morning to everyone. Thank you for joining us. Today is Sunday, the FCA Sunday TE session. And I request Dr. Minati Choudhury to take over and do the meeting. The FCA is same as the Bangalore chapter of IATA, and we have been doing this every Sunday regularly for over 1.5 years now successfully. Dr. Minati Choudhury, please take over and moderate the session. Dr. Vishwas Malik will be dealing with this subject of myocardial strain and its clinical utility in practice. Thank you so much.
Thank you, Murli sir. Good morning to all. Strain literally what mean is the excessive demand or the stress. And speckle is a small spot of patches of the color. But what are the relationship of these two factors with the echo? So Dr. Vishwas Malik, everybody knows him. He is a professor CTBA and cardiac critical care from AIIMS New Delhi, and he is also the dean academic of the IACTA. And he is going to highlight all these things, what is strain and what is speckle when echocardiography is concerned. Dr. Vishwas, over to you, please.
Thank you, ma'am.
Are you sharing your screen?
I'm trying, ma'am. Just hold on, ma'am.
So
Is it
before
visible, ma'am?
No, it is not visible. Before Dr. Share his screen, sir, there are lot many parameters to study the myocardium in echo. But why the strain and speckle, why these things are important? Again, the topic of highlight of this today morning.
Is it visible, ma'am?
No, now it is visible. You can go to the slide show.
Okay, ma'am. So, good morning, ladies and gentlemen. So, my topic for today's presentation is strain and speckle tracking echocardiography. So, medical imaging has never been static, and cardiac imaging is no exception. With each new technological advance, we view our patients in a different way. 15 years back, the echo was accessible to you, and we started having a look at our patients in a different paradigm. Sometimes the innovation.
Dr. Vishwas, can you please do the slideshow?
Full screen.
Full screen I have done.
Once more, sir.
From my side, it is done.
Can you just close the PPT and share once again, sir, because it's not coming full screen.
Okay. So Rajiv, can you do that? Because I think I sent you mail now. So is it possible for you, or should I? Because from my side,
no
it
problem, is. Sir. No problem, sir. I'll just share the screen. Just give me a second.
Okay.
I'll just do it right now. Okay, sir. Now it is coming full screen yours.
Okay. So should I start now?
Yes, sir. You can continue, sir.
So sometimes the innovations, they are dramatically different from the outset, and sometimes the innovation reaches its peak and the differences which are made every year or with the passage of time are little subtle. So the outline of my today's presentation will be under the heads of introduction, technical points, clinical applications, caveats and challenges, past, present and future of strain echocardiography. So why do we need strain? We have to think beyond ejection fraction. We do understand that left ventricular ejection fraction had multiple limitations in the form of it has moderate reproducibility owing to subjective estimation. There is a variability in because of the different ventricular loading conditions, especially in the intraoperative period. And last but not the least, the relative insensitivity in detecting subclinical disease. By the time the ejection fraction is decreased, it is too late for decision making. So essentially, the basis of strain imaging remains the analysis of myocardial deformation, which reflects the shortening and lengthening of cardiac muscle, thereby providing insight both into the systolic and diastolic mechanics as well as the dynamics of the myocardium. The strain term is derived from the everyday language, which means stretching, and it's used in echocardiography to describe the deformation of myocardium. So essentially, the strain is a fractional change in the length of a myocardial segment relative to its baseline length, and it is expressed as a percentage without any signal. The deformation analysis.
Rajiv, keep your mic muted. Except the speaker, all the other mics must be muted, please.
So strain is directly proportional to the deformation, and deformation is resulting from the applied force. More is the applied force, more is the strain. So strain is essentially the final length and the initial length divided by the initial length. So this is the initial length, this is the applied force. So the length is directly proportional to the applied force. When the more force is applied, it leads to more deformation, which is represented as L1 minus L0 divided by L0 into 100 to present it as percentage. So if the initial length is say 5 centimeter and the final length is say 8 centimeter, so the strain shall be 8 minus 5 divided by 5 into 100. This means 60%. The sign of plus is because it is a lengthening. If it would have been shortening, then it would have been minus 60%. So if the initial length is say 8 centimeter and the shortening after the applied force, it results in 6 centimeter. So it becomes 6 minus 8 divided by 8, and this becomes minus 25%. So for quantifying the strain, two things are important. One is magnitude and the other is direction. So based on the myocardial motion, there are three types of strain. One is radial strain, which relates to the motion from the endocardium to the epicardium. Circumferential strain relates to the motion along the circumference of the left ventricle, which means the curvature of the left ventricle. The longitudinal strain relates to the motion from the base to the LV apex. So this is the base and this is the apex, and this is the longitudinal strain. When there is lengthening, it is positive. When it is shortening, it is negative. Similarly, the radial strain is from the endocardium to epicardium, and the circumferential strain is along the curvature of the short axis of the LV. This is another pictorial diagram to clarify the aspects of the radial strain, the circumferential strain, and the longitudinal strain. So whenever there is a shortening, this means there is a negative strain. When there is a thickening, this is positive strain. Why? Because the thickening during the thickening of the myocardium, the length increases. And the circumferential strain, whenever there is a shortening, it leads to negative strain. So strain is positive when the systolic dimensions increase. That means the myocardial lengthens or thickens, and negative when the systolic dimensions decrease. The myocardial fiber shortens or thins. Therefore, the radial thickening is associated with positive strain. This means the final length is more than the initial length, whereas the longitudinal shortening and circumferential thinning are associated with negative strain, which means the, the final length is less than the initial length. There is another term called strain rate. It reflects how fast regional myocardial deformation occurs, that is, the rate at which shortening or lengthening is taking place, and has a unit of per second. So strain rate is equivalent to strain divided by the dimension of time. It is prudent to measure and evaluate both strain and strain rate, as they offer complementary information for the patient's condition, and both should be evaluated. For example, in patients with prolonged contraction, it may yield normal strain, but the strain rate shall be low. It is especially seen in patients with aortic stenosis and HOCM, hypertrophic obstructive cardiomyopathy. Their patient might be having normal strain, but patient's strain rate value shall be lower. So the normal values for strain are -16 to -24 for longitudinal strain, +48 for radial strain, and -20 for circumferential strain. So the average longitudinal strain in healthy strain rate in healthy subjects is to the tune of -1 to ±1. So strain rate is supposed to be load independent, while the strain is load dependent. So echocardiography, how do we measure them? So these are the technical aspects of the measuring the strain. So there are two techniques or methods to assess the LV deformation non-invasively. One is tissue Doppler imaging, and second is Speckle tracking imaging or echocardiography. So first, coming to tissue Doppler imaging strain, it's measurement of strain by using tissue Doppler imaging, and they are derived by integrating strain rate over time. And the myocardial tissue velocities are measured at 2 points relative to the transducer. And strain rate is estimated from the spatial velocity gradient, which means the velocity at point A and velocity at point B, and which is divided by the distance between the 2 points. So strain is derived by temporal integration of strain rate. This means that the strain rate is calculated by integrating strain rate over a period of time. So this is the tissue Doppler imaging. This is the point A or point 1, and this is point B. So the difference between the two velocity is known as the velocity gradient, and is divided by the distance between the 2 points, and which is strain rate. So in real time, for example, these two are the points of the measuring the velocities at two different points, and these are the velocity curves. So if we appreciate the two curves, this is the difference between the velocities of 2 points, and then the strain rate is calculated. All these values are given, but we should know the technical points, how these things are calculated by the software. So essentially, all these values are timed to the cardiac cycle. So this is the time curve, and this is the velocity curve, and it is timed to the systole as well as to the diastole. So there is a strain rate at systole, strain rate at early diastole, and strain rate at late diastole. What is segmental strain rate from the velocities? For if we there is a color coding. This is the base and this is the apex. If we examine the velocity curve at this point, that means the green color, you will appreciate that the velocity at the apex is minimal. And if we see the white colored curve, this means the base of the heart the velocity shall be maximum. So we see that the velocities from the base to the apex, they have a downward trend. So the velocities at the base, they are the maximum, and the velocity at the apex is minimal. What is speckle tracking echocardiography? Speckle tracking echocardiography is a technique for the characterization and quantification of the myocardial deformation. It's basically a grayscale based technique which is non-Doppler, angle independent. Both are different from tissue Doppler, and they permit more comprehensive assessment of myocardial deformation. So when ultrasound interacts with myocardium, it results in reflection and scattering, generating a finely gray shaded speckled pattern. These speckles are equally distributed within the myocardium and function as acoustic markers, changing their position in accordance with surrounding myocardial deformation and tissue motion. It is the movement of these speckles which is tracked by STE software throughout the cardiac cycle, and software algorithm extracts the displacement, velocity, strain, and strain rate within the defined myocardial segment. From this data, the software automatically resolves the magnitude of myocardial deformation in different directions and generates strain and strain rate curves. So speckle tracking strain is angle independent, and it calculates deformation in two axes, unlike tissue Doppler. Thus, it measures longitudinal and transverse deformation from long axis views and radial and circumferential deformation in short axis views. So STE is less susceptible to tethering or translation artifacts, which are very common in ischemic myocardial segments. They demonstrate displacement and velocity due to tethering. However, when we examine their regional strain and strain rates, it will be near zero. So strain by STE has the ability to distinguish active contraction from passive motion, which is a very crucial piece of information for clinicians to manage their patients, whether it is a passive motion or whether it is an active motion. So how does the software does it? So it is the longitudinal strain quantification is performed offline using a dedicated software package called as cardiac motion quantification, which is available with QLab 9 software. It can be done either on Echo machine or on the personal computer, whichever thing a person is comfortable with. And the images are, if they are not available on Echo, it is transferred to the PC and QLab 9 software is launched. An image is opened in the application window, and CMQ is selected as the technique for analysis. The software automatically generates a region of interest to include the entire myocardial thickness. This region of interest is manually adjusted as required to include the entire myocardium, avoiding the pericardium. Here, the clinician plays a key role because he knows the patient in totality, his echocardiographic data, as well as the angiographic data. So it is important to sometimes manually adjust the mapping of the myocardium. So software then tracks the myocardial speckles frame by frame and generates moving images displaying the tracking. So this is the mid-esophageal long axis echocardiography displaying the tracking and the velocity curves. So these images can be played back and forth and inspect the tracking. The same process is then repeated for the mid-esophageal four-chamber view by marking the medial mitral points and the lateral mitral annulus point and the apex. And then again, the tracking is observed and is examined by the clinician whether the tracking is appropriate or not. So the quality of tracking is visually assessed during motion playback, and if necessary, the width of the region of interest is adjusted to the wall thickness. Once the tracking is satisfactory, it is approved. So the software then divides the LV myocardial into 6 segments and generates segmental and global longitudinal strain. A color-coded parametric image that provides quick visual impression of the extent of segmental myocardial deformation is generated. So this is called quad format. Here, the color-coded region of interest, the parametric view. These are the velocity curves. These are the different myocardial segments with the strain values, and this is the curved anatomical color M mode picture. So this is the quad format, means it is displayed in the 4 formats, and so that a clinician can examine and make a viewpoint for his patient. The strain values for all the segments are averaged to obtain the global longitudinal strain, and the bullseye display is given for the whole myocardium. So here it is important to know the various color coding scheme. This is the good strain rate, this is the borderline strain, and this is almost a akinetic segment. So we can see that the negative means it's a shortening and the positive means lengthening. So this is the normal myocardium. So we should know the various signature graphs which we'll be looking at in the coming slides. So what is the caveat here? The caveat here is the variability. The same same image, so if the tracking is not appropriate, the same image can give different global longitudinal strain values. If the tracking is appropriate, gives the value of 21.2. So if it is not appropriate, if it is inside, the values are less. So it is important to, here comes the role of experienced clinician who can examine and who can appropriately examine the track the myocardium. And it is crucial to map the myocardium properly. Because of the inter-vendor and inter-software variability, serial assessment of GLS in individual patients should be performed using the same vendor equipment, means same echo machine should be used and same software should be used to compare the strain values at different points of time. The peak global longitudinal strain is in the range of -20 and it can be expected in a healthy person. If it is lowered absolute, there is a lowered absolute value, this means it is likely to be abnormal. It is usually said that there is garbage in and garbage out. If it is a poor quality 2D image, it will result in inappropriate strain values. If the 2D image quality is good, then the strain values will be more appropriate. So it's prudent when the regional tracking is suboptimal in more than 2 myocardial segments in a single view, the calculation of GLS should be avoided. Then the learning curve, the importance of learning curve. Usually it needs at least 25 to 50 case examinations to have a reliability on the strain values, and it takes more than 100 cases or maybe 75 cases to have a good grasp of the subject of the strain and then give appropriate opinion regarding the global longitudinal strain. So experience plays a key role for, it is not only a software gimmick, it has to be, the patient has to be seen in totality, and it requires like solving a puzzle. So it requires both the experience as well as the experience with the software. What are the current clinical applications of the patients? We do come across in our clinical practice of heart failure with preserved ejection fraction. So in such patient, strain plays a key role for managing those patients or titrating the therapy. Similarly, in valve disease patient, for example, aortic stenosis and mitral regurgitation patient, where the ejection fraction might be fallacious. So in such patients, it is important to take decision based on the strain values. For example, a patient coming of aortic stenosis went to intervene either by surgical AVR or by TAVI. Similarly, for decision making in HOCM patients and for cardiac resynchronization therapy for placement of the leads, sometimes you find that the leads are not the CRT is not benefiting the patient the way it should have been. So the stain helps in choosing the site of lead placement. Then for right-sided patients, for example, the effect of pulmonary hypertension on the right-sided heart and the complex congenital heart disease, though the RV strain software is not as robustly developed as it is for the left ventricular strain pattern. So the simplified clinical application is it's important to know the pattern recognition. For example, if we see the patient, here the strain values are normal, whereas in these segment it is borderline, and here it is almost 0 or akinetic segment. So the blue color, so it is like a nuclear imaging where you see the hot spots and the cold spots. So with this we can help, it can help us in prognostication of the patient or for guiding the revascularization therapy, that these areas are not revascularized or not amenable to revascularization, or at least they need revascularization. So if we can do something about it, then it is fine, or otherwise we need to prognosticate the patient. Similarly, this is the here in this pattern the strain is normal here, and here it is not normal. So here the patient will be, the ejection fraction will be normal, but the strain is different. So it is important to know this curve to detect the subclinical dysfunction, the pattern recognition for prognostication, and advise the therapy for revascularization. And again, it is important to examine the individual velocity curves, which are originating from different points of the myocardium, to know which area is problematic. So doing this, to assess all this, we should know the bullseye plot, the average GLS values, and the strain curve shapes. So the current indication, the established rules of strain is in the patients, for example, the patients who are in chemotherapy-induced cardiotoxicity, heart failure, aortic stenosis, ischemic heart disease, left ventricular. These are the established uses of strain. However, when the RV strain and the LA strain softwares, they become more robust, will be able to take better decisions for biventricular repair, one and a half ventricular repair, single ventricle physiology, whether they are suitable for or not, they might be including in the algorithm of the patients. And similarly, once the LA strain is more robust, we will be able to predict postoperative atrial fibrillation and the preemptive therapy for guiding for the better management of these patients. Thank you.
So you just go to the back screen, say just escape in this slide, and then you can stop presenting, sir.
Okay.
Yes, sir. Moderator, sir, Minati madam.
Thank you, Dr. Vishwas, for highlighting so much about strain and speckle tracking imaging. This is a relatively new technique, and very less people are practicing, but it is more valuable when you compare to study the ejection fraction of the ventricle or the function of the atrium as well in advanced strain imaging. and in comparison to the ejection fraction, because the previous parameters and most of them are dependent on some or some factors. Some are dependent on heart rate, some are dependent on the preload, afterload. So because this strain doesn't depend on all these factors, so this is more valuable. And some important thing I want to just highlight while going for a strain imaging, this is particularly for the student. So in the TEE, you have to take mid-esophageal 4-chamber, 2-chamber view and mid-esophageal aortic valve long axis view for the longitudinal strain, and measure in 3 cardiac cycle. This is to cover the entire QRS complex, and take the mid cycle for the image analysis, for the speckle tracking analysis. And in the short axis for the radial and circumferential strain, you take at the mid, basal and the apical level. That is important. Again, quality of image is important, that Dr. Vishwas said. For that, you have to optimize the gain setting and decrease the depth so that the left ventricle occupy most of the image sector. And in the longitudinal view, again, you have to avoid the foreshortening of the LV. And in the short axis view, and you have to see that entire LV should be as circular as possible. So these are important. Again, the grayscale frame rate, this should be kept between the 30 to 70 frame per second, because if you keep the frame rate low, so there is a long displacement of the speckle in between the successive frame. So you cannot go for a satisfactory tracking of the speckle. But suppose if you keep the high frame rate, then spatial resolution of the image get compromised. So this frame rate should be kept between 30 to 70 frame per second, which is important. Next is ECG gating. With the high quality ECG signal, you have to do the ECG gating to get the speckle tracking imaging. So all the image at the identical heart rate should be considered. So as I said, you have to take minimum 3 cardiac cycle, and take the image at the breath hold usually. So this is important. Again, another thing one has to know, while interpreting the strain and strain rate, it is been affected by certain factors like age, gender, and orientation of the imaging plane, and quality of the grayscale. So these things should be taken to the consideration while taking the strain and strain rate. And as strain, they detect the endocardial dysfunction, as Dr. Vishwas said, it is have both diagnostic and therapeutic implication. But global longitudinal strain, it is preserved. There is impairment of the global longitudinal strain even if there is LV function is preserved, because strain first affect the subendocardial region. So this is important, especially when the patient is receiving chemotherapy and there is ejection fraction may be normal, and if there is a impairment of the global longitudinal strain, that means you have to discontinue the therapy. And secondly, in the early myocardial damage occur in the severe AS and MR, even if the patient is not that symptomatic. That means if the strain is abnormal, then early surgical intervention is needed. And this is also get affected by diabetes, obesity, obstructive sleep apnea. You can think of which patient are having myocardial dysfunction, even if the ejection fraction and other parameter of LV dysfunction is abnormal in all these cases. And but however, and suppose there is compression from external source like constructive pericarditis and restrictive cardiomyopathy. So in these cases, again, longitudinal strain get affected also in the early stage. And so moreover, this strain speckle tracking, these are promising and it has a different important application. But one again have to remember that there is lot of vendor variability, and this is a major limitation. And standardization and imaging processing is also important. So also the learning curve.
Hello.
Hello.
Dr. Vishwas.
Yes, sir.
Nice presentation. You made us, it is difficult to understand But this one is patients with mitral aortic regurgitation with preserved LV function or more LV ejection fraction. What
Yes,
are the correlation in the strain and strain? Where one other one is strain and strain rate is dependent, volume dependent or preload no, independent.
sir. Strain rate is relatively load independent and strain is load dependent.
Okay.
So since in strain rate the dimensions of time is there, sir.
Okay.
So
In
strain rate is load
though
independent, sir. Sir,
in
however, nothing can be totally independent. It is basically more load independent.
okay. Then in patients with AR, we expect the ejection fraction in the initial stage is quite
Yes, sir.
this one. What are your comments with this strain?
Sir, it is important to measure both strain and strain rate in patients with preserved ejection fraction. Why? Because uh, sometimes we delay in decision making for intervention.
Okay.
So once the strain starts decreasing and once we examine the curve, once the so it is more important to observe strain and strain rate than dimensions.
Okay. Then you mentioned all throughout your class only about the ventricular functions.
Yes, sir.
Global it reflects first of all. How
Yes.
about the atrial? What is the findings? When you told some measures minus 25, minus 16 and plus 40.
Yes, sir. Plus
Yes, sir.
40. Sir,
How
the plus
about
40.
in the atrial this one? Whether
Sir,
only it's limited to the ventricular functions assessment or even the atrial function also.
sir, it is the software is not yet validated for left atrial strain, sir.
Okay.
So it is being validated, sir. It is available for transthoracic echo, sir. It is not available as of now for transesophageal echo, sir.
Okay.
So,
No, just out of the topic, is there any values like ventricular? How you given the ventricular this one values longitudinal, circumference, radial? Is there any like even for atrial? Is there
sir, I'm
any?
not sure because we have just started practicing now left atrial
Okay.
strain, but we have not means we don't have any values right now.
Okay.
I'm not aware.
Madam,
Dr. Minati, ma'am. Ma'am,
not
please unmute
audible.
yourself.
Not audible, ma'am. Rajiv. Madam, not audible. Not audible, madam. Just convey.
Audible now?
Yes,
Hello?
now audible.
Yes, ma'am, it's audible, ma'am. I think it's due
It's
to
audible?
network issue.
Now only
Yes, ma'am.
audible, madam.
So the electron is 45 plus 1 minus 10, 11. It is like that.
Okay.
So that's what the literature says. Again, it is not standardized according to the age and gender.
Okay. So whether by knowing the strain and strain rate, what all this one ischemia and infarction can be extension and all can be isolated or identified.
So it gives a value based on the bullseye plot, which gives individual strain values to all the segments, say 17 segments. So based on the coronary artery distribution, we can detect the regional ischemia. For example, if the minus, so in the anterolateral area, if it is minus 10, if it is, this means that it is less. it is in the borderline area. If the color coding will be less than the red. And similarly, if it is say 0, then it means it is a totally infarcted segment. So both the color as well as the value is important. And the bullseye, it is important to examine the bullseye plot and examine all the 17 segments in that plot.
How do correlates with the arrhythmias, sir? Arrhythmia and
Absolutely, sir. So if the strain values are less than -10 in multiple areas, more the number of areas, more arrhythmogenic the patient is.
okay. So more than 6 or 10?
No, sir. One is the value and the other is segments.
Okay.
If the value is less than -10 in more than 6 segments, then the patient is more arrhythmogenic. And these are just numbers. So, for example, 6 segments, sometimes the patients in infarcted segment, they are less arrhythmogenic than patients in borderline ischemia. So the two things are important. One is the absolute value, and the other is the involvement of the more segments. So this is so based on that you can prescribe the antiarrhythmic therapy or inotropes or dilators. So you have to titrate the therapy, do the strain, titrate the therapy, then reevaluate.
Thank you, Vishwas.
This is again important during cardiac resynchronization therapy.
Yes, yes.
So during that case, it is again not the longitudinal strain. The cardiologist usually take the radial strain. That is a more robust measure. And so where to go for the resynchronization therapy, and it is a better predictor for the response of the resynchronization therapy.
Absolutely.
Radial strain. And usually they take the time to pick radial strain to identify the latest change in the focus, in the arrhythmogenic focus.
For the placement of leads.
In RV, TAPS is most, you said it's not applicable.
The TAPS is applicable, but the strain, RV strain for software is not as robust or validated as it. TAPS is one
because
parameter.
we come across more with the RV failure rather than LV
Absolutely.
failure.
So there's another question from that during the posterior anastomosis in off-pump CBG, whether the strain or speckle tracking is reliable or not. Whenever the heart is positioned in a vertical manner, it is not a good idea to do the straining or speckle tracking or strain measurement during that period. Once the heart is stabilized, once the anastomosis is stabilized, since it is majorly a offline analysis, during the procedure, it might not be appropriate to do strain analysis.
In fact, mechanically also morphology is altered.
Yes, sir.
There is no more question in the chat box.
Yes, ma'am. So that we can conclude the session, ma'am.
We can conclude the section if there is no more questions.
Yes, ma'am.
Because this is a very tricky subject. Actually, one has to be
tricky and difficult
of
also.
the imaging plane and all. One has to see physically. That is very important while doing, to understand the strain
Yes.
and strain. There is a lot of physics involved also.
difficult to assess the graph also. It's not easy.
Yes,
to
It's
assess.
difficult to assess, but the common
Artifacts
thing,
so much.
so much of
Absolutely.
artifacts also during speckle tracking. You should not take the artifacts. That is very important to identify the artifacts. Otherwise, all these things will go in the count. So you will get a wrong reading of the strain and strain rate.
sir, we cannot rely on isolated on strain. So we have to
Yes,
examine the
yes.
patient, echo data, cath data, and then it is not isolated strain values which are important.
Only thing is it reflects you before much more changes of the ejection fraction functions.
Yes, sir.
It gives you an idea. It
Yes.
might goes for a downtrending
Yes,
function. It's
prognostication.
not. You cannot depend on the entirely whole. You have to depend on other, as you said.
If there is no more question, we can wind up. Rajiv, sir is there? Murli sir.
Yes. No, actually, sir is traveling, so sir is not available as of now.
Okay.
Ma'am, we can conclude the session, ma'am. Not a problem.
So thank you so much, Dr. Vishwas, for an excellent presentation. Thank you all the audiences. I hope student understood something at least. When you go in practice, you will understand more. So thank you, Rajiv, and thank you again.
Thank you, sir.
Thank you, ma'am. Thank you for your time. And thank you, Vishwas, sir, for your time, sir. Thank you very much.